Our next speaker is Amesh Adalja, practicing infectious disease physician who's an expert in this policy work on pandemic preparedness, response, biosecurity, amongst many other issues. Amesh is going to give his talk on government and American medicine. Please welcome to the stage Amesh Adalja.
Thanks for the introduction. Thanks for the invitation. Thanks, Greg and Ray, for organizing this this conference. I think it's a very important topic that doesn't get enough attention, at least not the attention in the right way. So what I'm going to talk about today is kind of the history of government and force in medicine. And one of the things I want to caveat this is that I'm an infectious disease, critical care, and emergency medicine doctor. I'm not and a pandemic policy expert. I'm not a health policy at large expert. I'm not a health economist, so have that caveat in mind. But I am somebody that interfaces with the healthcare sector in many different ways all the time, and I'm also the son of two physicians, so I've been around medicine and seen how it's changed over the last decades. So this is going to be an exploratory talk through what's happened from the last 100 or so years in medicine, and hopefully you'll get an idea of the trends that are there and why we are where we are. And I think Greg gave a great underpinning of how this all, what's going on in the thoughts and the culture. And then I'm going to kind of take that piece and say, if you have that as what's going on in the thought, in the culture, it shouldn't be a surprise that we are where we are. So all the opinions are my own. I have lots of affiliations and organizations that I work with and for. This is all my own thinking. So don't construe this as anything as an opinion of the U.S. government or any of the universities that I'm affiliated with. So in this talk, I want to do a few things. So what I'm trying to do in this talk is describe some of the major U.S. government efforts with healthcare, and then see that these trends were present from the very beginning of the industry, and then understand what the current status is of medical care in the United States, and then identify the restrictions that we see in areas of non-governmental medicine, that sliver that's left. And part of this is going to be to kind of explode the myth that Greg alluded to, that we have some kind of different system than other parts of the world, and that we're not a primarily social medical system. And I think lots of people, their turning point with this was the Affordable Care Act or Obamacare, where they thought something really changed. But as hopefully you'll get from this talk, many things didn't really change. This was just kind of not even a culmination, just an incremental move in a process that had been going on for some time. So the overarching theme that I'm going to talk about is, and this is something that Greg alluded to earlier, is that medicine is something that's new. This is something that really only came about in the last 150 years in terms of being efficacious. And it only became highly efficacious in the last 80 years. Antibiotics, antisepsis, so people like Louis Pasteur and Joseph Lister, all of those names are what made medicine something that could actually cure people, that people didn't get more sick, that this was something that worked. This is something that was valuable and allowed humans to flourish. Evidence-based medicine, procedures, everything changed. And when that happened, medicine started to become regarded as efficacious. This is something that works. This is something people should want or pursue. It became an intrinsic value, meaning that everybody should want it, everybody should have it, and this is the same thing as clean water. This is the same thing as a warm house in the winter. And that's the consumer ideal. That became a consumer ideal, that healthcare is not ideal unless anybody can get it anytime they want it for no out-of-pocket cost. That this is something that's just there, like the air we breathe or the clean water that comes out of our faucet. It's kind of a Garden of Eden mentality, that this is something that's there and it's good and it's just there for society to take. And it became a foregone conclusion that government was the vehicle that was going to that was going to provide this. And this isn't unique to medicine. We see it every winter when we read about heating oil crises and the government providing heating oil subsidies to people. Initially, something like broadband internet was thought of as a luxury, that only certain people have it. Now that's considered an intrinsic good, and broadband internet has to be given to everybody or to be provided by everybody by the government. So something that becomes, when something gets thought of not as a luxury, not as something frivolous, not as someone's hobby, then it becomes a societal goal to achieve universal access to this value by any means. And that's what happened with medicine. Initially in the United States, I think what was unique about it is that they allowed we had a private sector that was very robust, and government's role initially was, if the private sector fails, if we see that it's not achieving this consumer ideal, then it's a role for government. But if the private sector can do this, then there's less role for government. And I think that was the only thing that's really unique about the United States, is that they gave the private sector a role, and that's why we have a unique type of socialized medicine. The other point is that people talk about the American Medical Association, of which I'm a member, as this major bulwark against this. And I would say that that's a misconception. The AMA is a guild, and they're not really a bulwark against any of this. Basically, their function was to make sure that doctors came out ahead, or came out okay, that we still had the ability to drive fancy cars and be called doctor, or to get a nice parking place at the hospital, and have all of that societal prestige that doctors have. And then the rest of it really didn't matter. And I think that's kind of what we are now, that we've got a workforce of healthcare professionals that are esteemed, that have a lot of social status, that are considered in the United States upper class. And it doesn't really matter about all the other stuff, because we've been taken care of. And that's what the AMA tried to secure. That's what they still try to secure, is making sure doctors are paid high and have all of those perks in a different echelon of society, but not really caring about what the underlying aspects of this was, so long as it was positive, at least to the doctor lifestyle. So this is something that's been going on, as I said, for a long time, and I've got some, I think, quotes that I've pulled that I think are really good from Democrat and Republican presidents, and I'm just going to go through these because it's important to remember that the whole idea of universal health care or socialized medicine or one payer didn't start with Hillary Clinton or Bill Clinton or Barack Obama. It starts way back, even to before these presidents, to Theodore Roosevelt, a Republican president. So just a couple of quotes I want to read. This is from President Truman. "We should resolve now that the health of the nation is a national concern, that financial barriers in the way of getting health care shall be removed, that the health of all of its citizens deserves the help of all the nation." So we are our brother's keeper. This is tying everybody together in that three-man race that Greg was talking about. That's President Truman articulating, and he was probably the first major advocate for this, even though Theodore Roosevelt had talked about it. And he also cited the fact that only 20% or 1/5 of our population is able to afford the medical care they need. Now that means that there are 110 million people in this country who can't afford proper medical attention. That is a disgrace to the richest country in the world. So this was seen as something different, that you can't have any kind of inequity, and had to be remedied by government. President Eisenhower, a Republican: "American people are going to get the medical care to which they are entitled in some form or another." So this is already being seen as an intrinsic good, that you have to achieve this consumer ideal. If the private sector isn't doing it, if there are people that are having difficulty meeting their medical bills, then government has to intervene and take action. And then Lyndon Johnson: "Whatever we do or hope to do depends upon the health of our people. We cannot be satisfied until all Americans have available to them the best medical treatment that the best medical men can devise." No answer of how you create a system to do that. They just assume it's going to be there. It's an intrinsic good. We're going to be the government's going to be the vehicle, just like the government is the vehicle for clean water that comes from the earth into your faucet. The same way, the medicine is going to come out that way, and it's going to be great. And Lyndon Johnson was instrumental, but President Kennedy, his predecessor, really, I think, illustrates an important point. At this time, the United States had a semi-free medical system, even though it wasn't completely free, but they were looking to Europe for inspiration. Europe was what everybody emulated. Europe was what the avant-garde liked, and there's philosophers in this room that know that better than I do, that this was that they set the intellectual tone. And there's I think, really telling quote from Kennedy there, that the fact of the matter is that what we are now talking about doing, most of the countries of Europe did years ago. The British did it 30 years ago. We are behind every country, pretty nearly, in Europe in this matter of medical care for our citizens. So they're already viewing this as a goal. This is an achievable goal. This is something they're striving for, and we're behind. That it's a race to provide this. So this is not surprising that if you've got these leaders talking about this, that you get the system, and they're reflecting what's in the culture. This is what's happening, and you're starting to see this rhetoric, and that rhetoric is going to lead to government programs. And I think this quote from Senator Kennedy, President Kennedy's younger brother, really illustrates what the problem is here. As Ted Kennedy said, healthcare is not just another commodity. They're thinking about it differently. So this is not a Corvette. This is not some fancy luxury thing that only certain people could get. This is something that should be thought of as you get this irrespective of your ability to pay for it or the ability of anybody to provide it. It has to be there somehow in this Garden of Eden mentality. So I want to just take a little bit of a historical tour because, as I said, this was already something the government was starting to do. And if you look back, and I think the health policy people probably, I think they can correct me if I'm wrong, this is the first time you see the government involved, the U.S. government involved in healthcare, which was the Adams administration, so the second presidential administration in 1798, the Marine Hospital Service Act of 1798, where they were starting to now deduct money from the wages of seamen to fund medical care for sick and disabled seamen and build hospitals for the treatment of seamen. Here's a quiz question. Does anybody know what the most famous marine hospital is that still stands today and what it's called? The National Institutes of Health. It's the NIH. This was the funding bill for the NIH. The NIH was the marine hospital system that turned into the NIH. And this passed the House and Senate on a voice vote, which means there was no opposition to it. And President Adams signed it into law. So they were already thinking healthcare is something different we have to provide, even though at this point we're just 2 years after Edward Jenner made the first vaccine. So we're still at a very early age and a while away from antibiotics and efficacious medicines. So another important part of medicine is not just the federal issues, but the state licensure of physicians, and Greg alluded to this. So in the early frontier times, I guess, the United States, we had state medical societies and medical schools that would say this person graduated, or the state medical society would vouch for someone saying that this is a way that this person could be a doctor. And there were penalties for unlicensed practice. However, interestingly, there was a blowback against that type of state-level regulation against medicine, and that was during the presidency of Andrew Jackson, where many of these laws were repealed. And then they had a second wave of licensing laws in the 1870s. And then State Board of Medicines, which were basically populated by individuals from the AMA and their state medical societies, started to develop education and training standards, including for doctors trained out of the U.S. And this is how it stands today, that there's state boards of medicine that regulate who can practice medicine, what type of training they need to be licensed, and what types of standards they need to maintain their license. They also, when you think about issues of bringing doctors from outside this country to practice here that have been trained, they set those standards as well, saying that they have to do a residency here. So, for example, if you're a doctor that was trained in England and you come to the United States to work, if you do not do your residency training here, you have to start over, which disincentivizes immigration. The only country that has an exception to that is Canada, and U.S. have reciprocity, but that's what state boards of medicine do. They restrict the supply. They also are bulwarks against what we call advanced practice providers, or some people sometimes call them mid-level, so nurse practitioners, physician's assistants, nurse anesthetists, midwives, optometrists, psychologists, all of those individuals who have the ability to do some kind of healthcare delivery, but not all of it. They restrict how much they can do, and it varies from state to state. So they still continue to do this to this day, restrict who can come in from other countries and what training requirements, and then what other people, other healthcare professionals can do. And this is a way that the AMA has sort of worked hand in glove with government control of medicine. They've used it to their advantage to protect those high salaries, the Porsches, all the things that we want to have as doctors. The other thing that they do is that they restrict how you prescribe medicine. And I just use this as an example. Again, this is not completely exhaustive, but doctors have to, one way that we deal with force or government every day is when we prescribe narcotics. So as early as 1915, narcotics started to be treated differently, that they could only be prescribed in good faith and in the course of a doctor's professional practice only. So they were already auditing the way people used certain drugs. And from there we get the Controlled Substances Act and the whole Drug Enforcement Agency and the Diversion Control Program. So one way, a very concrete way that doctors deal with force and how much we're stipulated what we do. So the DEA dictates even what type of paper we can write a prescription on for a narcotic. Not a certain type of narcotic has to be written on this type of paper, but not on this type of paper. You can only call in this many refills for this narcotic, but 0 refills for this one. You can't even call a pharmacist for this one. It has to be on that special paper. And it has to be faxed. It can't be It has to either be electronically transmitted or faxed. It can't be, you can't give it to your patient. There's so many restrictions. That's how granular it can be with the DEA in terms of controlled substances. And it's not just for, there are other drugs that they have special monitoring programs too, but this is just an example of, but you grew up with that as a doctor, so you don't even notice it, because you've always known that there are special requirements, that you have a DEA number, that I can recite my own DEA number off the top of my head just now if I need to. That's just how you have to be able to interface with the government on any daily basis. What's your DEA number? And you can do it. What's your national provider identification? You have those memorized in your head because of how much you have to do. So I'm sort of jumping around here. And the other point I wanted to make is about the way people paid for healthcare. And this is trying to setting the landscape of what's happening before Medicare. And I think this has been identified by a lot of individuals, and Greg talked about it as well, is that when you separate the purchaser of healthcare services or the receiver of healthcare services from the one providing it, where cost doesn't become something they think about, you really have massive distortions. So we know from World War II, during the wage freezes, that employers needed ways to recruit individuals, and they made healthcare cost deductible from the income of a corporation as a way to encourage people to be employed at that organization, because they couldn't raise wages, but also as a way to provide health care for individuals. And then employer subsidized health insurance is the norm. That's what every person, a majority of people here probably have that. And that third-party payment issue, the fact that there's no concern for costs, really showed how unsustainable it was. And the thing is, this isn't insurance. If you think about what insurance actually is, in terms of what you do when you get your Allstate car insurance, you still worry about costs. You still think about what your insurance is going to provide and what you're going to pay out of pocket. But you're already starting to see that move away when third parties are paying for this in a way that's very different than any type of insurance model. And if you look at the history of this, many insurance companies didn't even want to get involved in health insurance because it was so different. The life insurance companies, they were not that interested in their health insurance because they saw once this was happening that this was not sustainable to their business model. So you had the rise of groups like Blue Cross and Blue Shield, which were not-for-profits, but very different than traditional insurance companies. So a couple of things happened before Medicare and Medicaid were passed, and I think Medicare and Medicaid is the turning. It's the closest pivot point that we see in American medicine. So in 1921, the Shepard-Towner Act, funding for state maternal and infant health care programs. So they were already giving money for health care for certain groups that they think are vulnerable. The Farm Security Administration was giving federal subsidies to states to create healthcare programs for farmers. Federal subsidies also for insurance for the poor, elderly, and underemployed. So at this time, states had their own healthcare programs, but the federal government is starting to now augment them by giving more money. In 1946, the Hill-Burton Act, federal subsidies to states to build nonprofit hospitals. So they're getting more and more engaged each time with trying to enter this industry and have states build up a robust system for their citizens. And then in 1950, the Social Security Act was amended to supply state welfare officials with resources to directly pay medical vendors. So they're becoming the payer now for many forms of healthcare. And one of the things that they're doing is that they've got this huge federal workforce now, and they can use this as carrot and stick to these insurance companies to play with them to do all of this stuff. Is you want to insure all our federal employees, then this is kind of how we're going to do it. The government's going to take an interest in this. So all throughout this thing, that they're using that as a big, the insurance companies are sort of putting up some resistance, but not complete. And one of the carrots they get for this government stick is you can insure our federal workforce, and that becomes more and more compelling to people. The other thing that happens is that states are regulating insurance as well. So we talk about what Obamacare did, or the ACA did, by setting this kind of level that what things needed to be covered, which things had to be part of an insurance plan that would be approved. But states were doing that long before them. Not all states. Some states had differing requirements, and that's why people once used to think about interstate insurance as a way to kind of get around some of that restrictions. But states were doing this for a very long time. Insurance was, I think, basically non-existent if you think about what insurance means. And I alluded to this earlier. Insurance involves weighing risks and making decisions on who or what to insure, what benefits, how to charge people. And if you're thinking about, you want this consumer ideal of healthcare for everybody without any thought of cost, the best healthcare that you can get, health insurance can't actually do that. It's not insurance anymore. because it's a totally different thing. It's a social welfare program. It's not really insurance. And I think that's what's striking to me, to think of it that way, is that we villainize the health insurance companies all the time. Every doctor has problems with health insurance companies, but you have to realize they're not even acting like insurance companies anymore, because they've basically been legislated out of existence. Their whole practice is dictated by government of what they can actually offer as a product. And they're not able to make decisions the way anybody would to try to weigh risks of, should I get, like, if you're buying an investment, if you're investing in something or you're buying a house, you might ask questions about, is this a place where there's earthquakes? Are there tornadoes? Does it have a basement? You can't do that in health. These insurance have to issue it. There's a concept called guaranteed issue, that you just you provide the health insurance if someone actually wants to purchase it, without any kind of idea of who you're giving it to. You get very little ability to discriminate amongst different risks or different plans, and then you have to give everybody whatever the government says has to be included in an insurance plan, or it's not really insurance. But it isn't insurance to begin with when you start having the government dictate all of that. But the government then redefines what insurance means. So it's a very complicated mess. But in general, what it does is destroys the entire concept of insurance in a way that's very unique to health insurance versus life insurance or car insurance or other types of insurance products that people sell. And now I'm going to move to Medicare and Medicaid, and I just have a little bit of facts about it. So as I said, this was something that Theodore Roosevelt started talking about, Truman pushed very heavily, Kennedy pushed very heavily, and then Johnson eventually got passed. And in the interim there, you had Eisenhower, who was also going to had his own different plan, which was very similar to Medicare. It was bipartisan, and there's a quote from LBJ there. Mr. Eisenhower is now for it. Mr. Nixon is now, or this is around that, or this I can't remember who actually made the quote, but Mr. Eisenhower is now for it. Mr. Nixon is now for it. Mr. Kennedy is now for it. I don't know anybody in government who is against it. So to think that this was something that Democrats did and Republicans didn't go along with that's another myth that needs to be blown up, that this was something that was bipartisan and it would have happened in one form or another, irrespective of LBJ. It would have been something that both parties were moving towards. And what Medicare and Medicaid do, for people that don't know, it starts out as something for elderly individuals above the age of 65, and then gets expanded to individuals with certain disabilities, end-stage kidney disease, Lou Gehrig's disease, or ALS, and it has a couple different parts. It started out with Part A and Part B. Initially, it was really about paying for hospital costs, because that's where the rise had been in terms of cost, because, again, medicine got efficacious, more procedures, more surgeries, more things were being done in hospitals, prices rose, and that's where they were worried about elderly not being able to afford. So initially it was hospital and skilled nursing care in Part A, and then Part B was part of that, which was medical insurance that you would take to your doctor. And then several years later, they made something called Medicare Advantage, which is basically a very HMO heavy. I'll get to that in a second. It's more meant to more mimic the private market in insurance, and you can opt for that. And it was all initially financed through a payroll tax, which was around 2.9% that both employers and employees had to pay, and then it's increased to 3.8%. And that's how it started. And almost immediately after it started, it was underestimated how much it would cost. And now it's over $990 billion, the budget of Medicare. And Medicare was also passed along with something called Medicaid, which is where federal government gave matching funds to states to provide medical assistance for individuals who are below a certain poverty line. So those two things were codified in 1965, and that I think really marks a turning point where you have the government being the primary payer of healthcare for almost everybody. Another thing that Medicare does that's not quite noticed by the general public, or that they don't understand, is that they fund graduate medical education. So once you finish medical school, you do a residency, fellowship. That is usually provided for by Medicare. Medicare pays hospitals. They pay them a lot. So they pay a resident. When I was a first-year resident, I got paid $36,000 a year. But the hospital that I worked at got paid about $100-something thousand to have me there. So that they, in that way, indirectly influence specialties, how much money they're going to subsidize for slots in emergency medicine versus vascular surgery versus infectious disease versus whatever. They control that amount of money, which hospitals respond to, and increase or decrease the number of slots that they're going to offer, because they want that Medicare incentive, that money. So they also control the supply of physicians in that way as well. So they really almost cradle to grave in medicine. They have an aspect of what you're doing. And when you want to become a doctor, you will engage with the government no matter how much you try to avoid it. And that's just Medicare and Medicaid. You can also think about the Veterans Affairs medical system. It's over 100 hospitals, and initially began after the Revolutionary War. So I didn't include this in, so this was before the Adams administration, where the federal and state funding was going into a system to take care of veterans. And then in the 1920s, Veterans Homes started providing not just kind of places for them to live, but hospital level care. And then by 1947, over 100 hospitals, and VA hospitals are all over the place. They do liver transplants, they do kidney transplants. They're just like any other type of hospital in many areas, and they are one of the biggest cabinet bureaus. If you think like the budget for the VA is very, very high compared to many other cabinet level positions in the United cabinet level agencies in the U.S. So it is a major issue. And then that's not to mention things like TRICARE, which is the civilian health benefits for U.S. military dependents and retirees, which is administered by the Department of Defense. So I'm giving you these as examples of how much the government does in the sector. Or the Children's Health Insurance Program in 1997, where they give matching funds to states to provide child health care for those who are not Medicare eligible. So it's raising it up. How many children are covered under that? That was done during the Clinton administration. And the thing is, you're getting more and more of these types of programs where they're covering more people, and then they're also dictating what you can do. So all this funding is out there for these hospitals. They all want it because they wouldn't otherwise. They would be giving charity care, and it's much better to get some reimbursement rather than none. And they use that as a carrot stick as well. And in 1986, they passed a law called EMTALA. The Reagan administration passes this law, and it stands for the Emergency Treatment and Labor Act, which basically says that if you participate in Medicare, and almost every hospital participates in Medicare, you have to give a medical screening examination for anyone presenting to the emergency department and stabilize that condition, irrespective of anything. So now this is basically mandating, if you want Medicare dollars, which all hospitals need to have to survive, you have to treat everybody, at least stabilize them, as a condition of getting that money. So EMTALA means you cannot turn anyone away. This is, again, going back to what Senator Ted Kennedy said, healthcare is not just another commodity. That's what they're doing here. A couple of other issues. So the Ryan White Care Act in 1990, payer of last resort for HIV/AIDS, all organ transplants, bone marrow and cord blood transplants, all done with government permission. There are major government organizations all run through the Health Resources Services Administration that decide who can get a transplant, what are the criteria, how do you match donors and recipients, what types of procedures and protocols have to be in place. And they also they outlaw any kind of remuneration for anybody that donates a kidney, or even they're trying to get some kind of reimbursement just for the medical expenses is even very, very difficult because of the way the government has written this. They do allow some compensation for bone marrow donors. They cover anybody with leprosy or Hansen's disease. That's automatically covered by government. We also have federally qualified health clinics, which are run by the federal government to provide primary care. The Indian Health Service, over 24 hospitals in the Department of Interior that takes care of all of the healthcare needs of any tribal citizens. And then we also have state and local health department clinics. So in a given town, for example, you may have a place where the STD clinic or the tuberculosis clinic, that's run by the government. So these are just more and more things that the government does in healthcare. There's, as we talked about, they also tell you how to practice. There's restrictions on certain medications like narcotics. For example, methadone. Methadone can only be given at a special federally certified center. You can't give it anywhere else. And it has to be given only one dose at a time. It has to be given in a way that they can actually look to see that you've taken that medicine, that you didn't pocket it or suck it in the side of your lip. There was another drug called buprenorphine, which is another narcotic drug that's used actually to wean people off. That was also restricted. You had to take extra 8 hours of time you had to spend to be able to license it. There are other medications as well. Certain cardiac medications you have to have special permission to prescribe from the DEA, from the FDA, from organizations that are restricting it. I didn't even get into abortion-related restrictions. There's so many that what you can actually tell a patient, what you have to do. Do you have to have admitting privileges if you're going to provide abortions at a hospital, or are you just doing it in a clinic? What do you do with the abortion pill? All of that stuff regulated completely and dictated by government. IVF restrictions. Can you use 3 people to make a baby, which somebody did? That's an interesting story on its own. Illegal in the United States, but can happen in other places. And then they also use these things called Medicare performance measures. So somebody writes a paper that something works really well, that they do a study, and for example, let's say sepsis, that people do really well when you give them fluids really quickly. You do this, you do this, you do these types of things. And it's a paper, and it starts to change people's behavior. They start to do it. Then the government makes that a performance register for Medicare, saying, if you don't do it now, we're going to deduct points off of your Medicare reimbursement. We're going to knock 3% off or 1% off. So when something looks good in a medical paper, then it becomes almost force of law, not quite force of law, but very akin to it in terms of what hospitals now have to do in order to get their full Medicare reimbursement, which is what they need for their viability. So they basically tell you how to practice. So now there's certain things that happen. So there was a very famous sepsis paper, and some people in the crowd probably know about it, about all these things you need to do for a septic patient. And sepsis is the end stage of an infectious disease. And it worked. The paper was really great, and it changed practices. But sometimes it doesn't apply to the patient in front of you. But now you have to write this paragraph. I did not apply I didn't give this patient 30 milliliters per kilogram of fluid because I thought it would be deleterious to the patient because of this person also had volume overload from this. You have to put that in the thing, or they'll ding the hospital. Or if you give a person or for a stroke, if you need to give them a clot-busting drug within 30 minutes, and if you don't, because you're on the fence, you don't know if it's a stroke, there's some issues, you have to say, I didn't follow your 30-minute recommendation because of X, Y, and Z. You have to actually include that in the medical record so the hospital doesn't get in trouble. So they do come down to that point of how to practice. We've also heard a lot about health maintenance organizations. They were sort of this devil that people talked about, but again, they were really thought of as a creation of the insurance companies. But what they were was a burgeoning model for health insurance delivery that got a huge push by a Democrat, by a Republican again. The HMO Act, 1973, Richard Nixon passed this, which subsidized them, made them the kind of norm that people wanted to do. So you have them looking at healthcare. So the government is the one subsidizing. Health insurance companies are sort of in the mix there, but they're all looking at trying to contain costs because this whole third-party paying thing has gotten out of control. So they're now trying to ratchet it all back. And by subsidizing HMOs, that's one way they think they're going to decrease healthcare. So this is just another aspect of government creating a problem and then creating another problem to try and solve that problem, which makes the problem worse, which then they want another problem, then they have another solution to solve. So we also talk about medications, the cost of medications. And I want to give you a few examples, not to belabor you with all these little details, but when the cost of medications has gone up, government started to pay, has been trying to pay for them. And we talk about the idea of price controls for drugs as if they don't already exist in the United States. So these are several programs. So the Medicaid drug rebate program. So you get rebates based on sales to Medicare beneficiaries as a condition of having their products covered by Medicaid. So if you want your drug to be covered by Medicaid, you have to give patients a rebate. And then there's this whole other process called 340B, where drug manufacturers have to provide outpatient drugs to certain eligible healthcare organizations at significantly reduced prices. This is now certain individuals get their medicines cheaper than other individuals. So they're already dictating how much, or they are dictating how much an individual pays for medicine based on their whatever demographic or social factor that they're trying to use. And the thing is, this creates middlemen and people who do these negotiations, and now you have a whole industry running around with the Medicaid drug rebate program, 340B. They're called pharmacy benefit managers, and they spend they get a lot of money working as middlemen, and they become an industry, they become a lobby unto themselves, who then kind of make these things stay forever in place. Vaccines for children under the Clinton administration, no-cost vaccines to uninsured children, and then the prescription drug benefit added to Medicare, again, not by a Democrat, but by President George W. Bush, which was the single biggest entitlement increase in the history of the country. So when you do all of this, what you've created is a major wedge to quote-unquote negotiate drug prices. So when we think about the fact that people talk about price controls, there already are massive precedents there, and Medicare itself is the wedge to get all of this to happen because that covers so many people. Hospitals themselves are also regulated, and this is something that came out very clear during COVID-19, is that we had no healthcare capacity, that we couldn't handle that surge of patients, that we were in crisis standards of care. And people think that, well, why can't hospitals expand the way Zoom expanded when people wanted to use the internet? Why can't they do that? And it's because of many different laws at the state level. So there's something called certificate of need, which is basically if you want to expand your hospital, even if you want to expand your ambulance, if you want to make a new ambulance service, you have to petition the government, the state or local government, and your competitors to say, is there actually a need for this? We want to make a new wing in the hospital, but your competitors say, well, no, you don't really need that wing. And it doesn't happen. So there are many states that have certificate of need laws that have made it much, much harder to expand hospitals. You have to have a licensing of facilities. So you might have room in your hospital for 5 extra beds, but those aren't licensed beds, meaning the state hasn't approved you to have those 5 extra beds. So you have to apply to the state to say, can we license those 5 beds to use them? And then the staffing ratio. Some hospitals, some states will say you have to have this many nurses for this many patients. All of that stuff can be regulated at the federal or state level, and it's just makes it impossible to run a hospital even like a business. It's the opposite of that. It's basically completely constrained by multiple levels of regulation. So now with all of that background, and most of that this is all occurring before the 2010s and the election of Barack Obama. I don't think anybody at that point would say that we had a free market in healthcare, or that this was free enterprise health system. So when you see the Affordable Care Act, it's basically just taking this hodgepodge of all these regulations and kind of codifying them together. So there were certain things. So there was certain things that were new. So the mandate for health insurance, where you had to buy health insurance as a condition of life, or face a tax penalty. That's been removed, so the mandate is not there, but that was one of the new things. But it's interesting to know that mandate was because the ACA wanted guaranteed issue, meaning they wanted health insurance companies to not look at any pre-existing coverage. So the health insurance company said, well, we can't do that unless we have more in the pool to cover those pre-existing conditions. So that was kind of a tit for tat with the insurance company who were negotiating the ACA with them. Dependent until age 26, which means you can stay on your parents' insurance. No limits on benefits, restrictions on differential premium pricing. You can't charge different people different things. Must cover preventive services without cost sharing. Exchanges to sell policies, and so those are the exchanges that people can buy on. 80 to 85% of revenues of the insurance company to be spent on benefits. So if you're an insurance company and you can't use that for anything else other than benefits. So they're already saying how much your profit can be. Medicaid expansion, 41 states took that expanded Medicaid. Cadillac tax is a 40% tax on employer-sponsored healthcare. So if you got a really great insurance plan from your employer, now that's considered income. So you have to pay a 40% tax on those benefits as well. And I think it's important to remember that this was mostly borrowed from the Republican plan in Massachusetts, which I just kind of put them side by side. It's almost identical between Romney Care and the Affordable Care Act, which was again a Republican plan that was used as the template for the Affordable Care Act, only with some federal changes in it. And I think, and before that was the Clinton healthcare plan, which failed in 1993. And it was almost, and had very similar things as the ACA, but it was a lot more stricter. It was basically going to force people into all of the exchanges and over time kind of almost outlaw private insurance, de facto outlaw it. But that was something that was defeated mostly because of mostly not so much because people disagreed on the ideal. I think it was defeated because people first of all, didn't trust the people that were advocating it, and there was much more about you choosing your doctor, getting in between the physician-patient relationship. That's how it was really, I think, defeated, is because people were trying to say that this is going to create a wedge between doctors and patients and worsen care. But in the end, I don't think it was much of it's not surprising that it was passed, and I think we're almost there with Obamacare. So a couple of things I wanted to talk about towards the end are some of the market-based solutions that people have been advocating for. So the first things were medical savings accounts, which are now called healthcare savings accounts. And these are tax-free accounts where you can take money and put it away tax-free, just like you do for a 401k. But it's not just like that. You can't just put $50,000 away one day in it. You have to ask, the government gives you limits. So any year, and the current limit is $3,850 per year. And you can't just have a healthcare savings account. You're required by law to have a high deductible insurance plan to couple with it. You just can't use your own money. You have to have a health insurance plan with it. So you're doing this by permission. There's also flexible spending accounts, where employers can spend money tax-free on qualified health expense. So you have a certain amount of money. So these are all things that the government has created to sort of give you some semblance of control. But you can see what they do there is they basically kneecap the entire thing. They make it not a threat to the other system. You'll hear, I think, in one of the panels about concierge care and direct care, where a patient can directly contract. But the way they've done this is they've made it really hard to make this a viable alternative outside of certain specialties like like primary care or ophthalmology or plastic surgery or dermatology or pediatrics. Because what they do is say, if you take care of anybody that's eligible for Medicare and you charge them differentially you can't charge them differentially for anything that Medicare covers. That if Medicare covers it, you can't charge them anything different, which makes it very hard to do this for many specialties. And number two, if you work in anything in a hospital, you're going to be taking care of Medicare patients. So if you're a hospital-based doctor, you're not going to be able to do anything direct care because you're going to have to take Medicare as a condition of being on staff at that hospital. So you can't opt out. And it makes it very, very difficult to actually see this becoming a viable challenge in all of medicine. So as I said, this is one cannot charge a Medicare enrollee different price for covered services. And I think that, as I said, all major medical centers are Medicare participating institutions. You cannot live in the healthcare world without Medicare because it's the biggest thing, the biggest entity or the biggest issue in medicine. And what it's done is created this whole atmosphere where you can't get around it, and it controls everything else you do, even if you don't want to do it. So I think that if you think about what Greg said earlier, that this is a myth, I think hopefully some of that concretizes what it's like in medicine. And the thing is that we all grew up, all of the doctors here grew up when all these things were already de facto. So we don't know what it would have been like without it. This is how it all started. That medicine was always regulated in a very heavy manner. So it's all unseen. As medicine was growing up as a field, as it became more efficacious, the controls were going with it. So they were maybe one over the other. So you don't actually know what free healthcare would look like, what things weren't pursued, what healthcare could be like. And I think that this is basically de facto socialized medicine. And one of the things that I think is that everything that you do that's outside of medicine or outside of government healthcare is done by permission. You're not doing anything because that's just the area that the government has left alone. They know about it, and you have to have permission. Like if you want to donate, if you want to give money to your healthcare savings account, they tell you how much you're allowed to do. More than that, it's illegal. If you want to work in a direct primary care practice, they restrict on which patients you can see, so that you don't cannibalize their patients. And I didn't even talk about things like the FDA at all. This is a whole other talk about where government regulation. It's really, I think Greg put it well to call it a myth, because it's just something that I think is just not quite understood. We have a different type of socialized healthcare system in the United States. And I think one of the things is, how is it staying viable? And I think it comes back to, that line from Atlas Shrugged. You'll do something, Mr. Reardon. You figure it out. That we've been able to figure it out because there's people that like medicine, that like this field. And I always think of doctors as almost entrepreneurs, taking the findings of science and bringing them into people's lives so that they can actually make them actionable. And if you're fascinated by that, I think that works. But I think we're in a position where many doctors are, next slide, many doctors are kind of frustrated. And I'm going to get to that in a second. But I wanted to, the thing is, if you look here, the top table shows you percentage of tax-funded spending and you can see the United States is very high ranked, even higher than socialized medicine countries in terms of total and tax-funded healthcare expenditures. And you look on this table from 2013 to 2024, you can go across 67.1%. So total tax-funded spending is 11.2% of GDP, which is higher than what you would call a socialized medicine, and 67%. So that's basically all of it. I mean, there's not much, and to call us not a socialized medicine country where it's 11.2, this is tax, this is government spended GDP, not all Medicare, not all dollars. 11.2 is coming from the government, and in England it's 7.3. and we talk about the NHS as a socialized medicine system, I don't really know that that has a distinction with any kind of difference, because it's more here. There's more government spending of healthcare here as a percentage. And then on top of that, you've got private spending, which will take that up into maybe 25 or 20 to 25%. But it's that little, whatever, that's a mystery to me, is that sliver. Because you can look at Canada there, it's 7.2%. And just yesterday, I had to call in prescriptions for a Canadian healthcare executive in New York City, that she would have someone drive and pick them up because she can't get them there. So there's differences in styles, and we still have some sliver that seems to produce great things. And I don't know how it does or how long it can, but that's what's kind of going on. But I think it's, there's one thing to remember is that there's no principled opposition to this. There never has been. The American Medical Association was not a principled opposition. They were basically voicing guild-like concerns, trying to make sure they were going to be okay. And I think so long as medicine is seen as the intrinsic good and the dominant philosophy, this is going to be the trend. And it shouldn't be surprising that this was the trend. But I think that there's some first things, Greg really wanted to focus on some concrete first steps. And I think that there's some interesting things that at least I think about. And I think it's about allowing the market-based solutions to burgeon and exist, not without permission, but as a parallel program, one that allows people more choice, one that might be more efficient, just like, for example, private schools and charter schools and Montessori schools exist in parallel, and they're allowed to do so, and they've been seen by the general public. Or last night we were talking in the dinner how Uber exists parallel to the taxi medallion monopolies, and people recognize that. And I think you allow that to happen, it may get people to think differently about this. Because, for example, in the UK, they have this NHS system, and then they have a private system on top of that. Their private system is much more tolerant than our private system in terms of how much they get involved and regulate. And I think we can learn some lessons, actually, from them. I think we need to remove Medicare regulations on concierge practices. We just need to allow people to be able to contract with people freely, free association, without this Medicare carrot and stick. Lift HSA contribution limits. It shouldn't just be $3,500. It should be whatever you want to do. I mean, the same is probably true for 401ks. Allow tax deductibility for individuals so that they can buy a health insurance plan and not have income from pre-tax dollars. Expand the scope of practice for APPs. We need to stop this guild mentality of if doctors can do this, nurse practitioners can do that, and all that fighting. I think that will make more freedom in this field. And then allow different insurance products to be sold. So, for example, last night we were talking about these guilds that come together, these mutual aid societies. But I did do some looking into that, and they were kind of exempted from the ACA. So if a mutual aid society exists, but you had to have been in existence since 1999. If you weren't in existence after 1999, it doesn't allow you to exist as that. So there's a lot of innovation that's being stifled because they don't want a competitor to the system that they have. And I think that we have no idea what the alternative business practice models would be. And just going back on a couple of things, when you think about people say force in medicine, it's not as if that there's, as I said, a government person in the hospital telling you do this, you do that. It's much more subtle than that. It's the way you're brought up in that system to be responsive to all of that and understand, and to basically take as a foregone conclusion that it's the government that's telling you how this field should be run, what you should do, what you shouldn't do, what guidelines you should follow, what guidelines you shouldn't follow. And you've all been brought up in that, and you don't know anything different. So when you think about most medical students today would support universal health care, would support all that stuff, it's because they don't know anything different, and they've only grown up around that system. And we have this mongrel mix where there are bad things that happen, and most bad things get blamed on the whatever sliver of private insurance is left, but it's that private insurance is not really even fully private. And I think that's one thing that happens. And you don't get they always talk about the best and the brightest not going into medicine because of that. And I think that's probably already happened. I think we have a lot of people who memorize, people that they're bright, but they're not the brightest, and they know that they're going into medicine for a good job. And I always get frustrated because I tend to be obsessive about medicine and reading and keep refreshing the page on the New England Journal of Medicine website when a new issue comes out to see. And I always ask my parents, why aren't people like that, or why don't they? I used to ask them that, and they would say, well, I would always be frustrated. Nobody's keeping up. Nobody does anything. They don't really care about medicine. I'm like, why did they even become a doctor? They should have done something else. And my dad said it's better than ditch digging, and that's basically what's happened is that that people think of medicine, it's a good living, and you learn all that stuff, you memorize all that stuff in medical school, you keep up, but it's not considered, I don't think it's the best and the brightest anymore. I think it's people that, yes, they get paid, yes, they're above average intelligence, and they know how they're competent, but it's not where you're seeing, it's, stifling innovation. And then I think it does turn into, if you think about burnout and all that, every medical journal has things about doctor burnout. I think that's part of it, is because, yes, you're making it into ditch digging. And that's why people are getting burned out, because there's no freedom, but they don't know anything better. Maybe they just said medicine isn't all it was cracked up to be, because they don't know anything, and they hear about what it could be like, or they see these TV shows like on TV show ER, how cool it looks, but it really isn't like that. So I hope that was interesting to you. That was kind of a whirlwind tour of my own thoughts on this, and hopefully that concretized some things and blew up some myths about where we are, and I'm happy to take questions. Yeah, Robert?
Yeah, I was surprised at how early the inroads the government made into medicine began with the Adams administration. How bad was what happened during or after the Revolutionary War? And I ask because you can imagine, since military is a legitimate function of the government, that if a soldier gets their leg blown off, that it would be proper for the government to attend to that for the duration of however long that is needed. Was it something worse than that? Were the programs you mentioned already violating rights more than you would expect from?
No, only in the sense that some of them may have been funded through tax funding, but no. But they were basically direct payments, almost like that they would just cover the care for people that were injured or needed or became some issue service connected to what they did in the Revolutionary War, which is still the core function of the VA. Still does that. It's just the argument was that the VA, when they were building on what happened in the Revolutionary War, they could have just paid it straight out as part of your contract as a soldier, that we're going to cover this through some means, but. It's kind of more after that, but in the beginning, no. I think it was just very clear. This is related to your service, and that's part of the agreement we have with you that you became a soldier. We'll just go this way and that way, and then back. Okay, I'll just go these two.
Yeah. This might be an incredibly naive question. I can't decide whether it's super naive or super complex. But in your opinion, how would you characterize the root of the Garden of Eden mindset? Like, where does it come from? Why are people that way? Why isn't freedom more compelling? Why are people so vehement that these things exist and we can just distribute them?
So I'm not a philosopher, so that's a better question for Greg or one of the philosophers here. But I think it's very common that people don't understand that medicine has to be produced. That it's not just something that's there for the taking. But I think the Garden of Eden mentality is present for many different things, not just medicine. People think about it they think of that as an ideal, that you don't have to work for what you want to consume. That the goods get there somehow, and that they don't is some deficiency of this world, is how I would think about it. I think it's a really great quote from Ayn Rand that I think that she says something, whatever existed in the Garden of Eden was not a human. Something like that really concretizes it. It's just a total different view of what life is about, I think. But I would defer to the philosophers for any more. That's how I think of it, though. But it's a long-standing problem. Yeah.
Couple quick comments and then a question.
Or was that just basically protectionist?
I think it was basically protectionist. I don't think anything, because we're still at a period where medicine is not very efficacious. So you're going to a great doctor, a bad doctor, there's probably not much difference because there was really no evidence base that they were operating from. But I think it came to the point that then doctors started to get more organized, more medical schools started getting built, and they wanted to make it a profession, and then they wanted to bring those licensure laws back. Christy? Yeah, I definitely think that there's definitely much more emphasis on trying to put people into categories, but then you can then fit them in easily into a guideline, which I think is what happens when you kind of get cookie cutter medicine, where people are trying to do what's best within the constraints of the system, and you get you want that patient to be able to be easily treated by what we already know, and it's very hard to individualize treatments that might not be covered by an insurance company, by Medicare, Medicaid. So you're trying to get them into that box in order to make it fit, even if it doesn't completely fit. There is a generalized trend for precision medicine and individualized medicine that's been going on, not in every part of medicine, but it's definitely taken off in places like oncology, for example. So it's coming back. At least people realize that you get better outcomes with individualized medicine, but it's not everywhere, and you do spend a lot of time trying to navigate to get certain treatments that might be individualized paid for from insurance companies because that person doesn't fit neatly in a box. So I think the system almost forces it to be you have to put people into kind of different categories and then follow those guidelines, and those are easier without any kind of problem where you have to call an insurance company for prior authorization before you do something. It's a big mess, but I think it's bureaucratic in most of its nature.
Yeah, we spend a lot of time just trying to figure out how to get the thing that you actually need.
Right. And there's tricks, and doctors get good at that, and you have like an office manager in an office that knows really well how to navigate all of these things and get things